Hi, this is Dr. Bob Dannenhoffer, Public Health Officer for Douglas County, and we're doing another of our Facebook Live updates. You may notice it's Tuesday night. We switched from our usual Monday nights to better accommodate other people's schedules, but we'll be here every Tuesday night and again every Friday night to talk to you about COVID. I'm wearing my new fashionable balaclava. You can get these at Lowe's, and actually it's quite nice. And so I'm going to take it down so people who read lips can see my lips. Again, this is Facebook Live. This is a time for us to answer your questions, but we'll get started by going through the world situation about COVID. The world situation is pretty grim. We're now over 10 million deaths and over 10 million cases and 500,000 deaths. That's a lot of deaths. We still have about a 5% case fatality. That is, for every case that's diagnosed, about 5% of those are dying. We were hoping that would go down as we were finding more lower symptomatic cases or asymptomatic cases, but we've not really seen that, suggesting that this is still a very active disease. Still very active in the US, Brazil, India, Pakistan, Bangladesh, kind of all over the world. This is really taking off in almost every continent, although, interestingly, there are some places that seem to really have gotten this under control. I think Taiwan has not had very many new cases. I looked, New Zealand the other day had 4 cases, so New Zealand, a country of about 5 million people, only 4 cases. Australia thought they had a big outbreak that they had 45 cases in one day, but again, that's about 1 case per million. There's 350 million people in the US, so obviously we're doing many, many, many times more cases than they. We're still worried about outbreaks in underdeveloped areas, so starting to see some in Iran and Iraq that really have troubled healthcare systems, so we're worried about that. The number of cases in India is staggering now. The number of people in India is huge, so their overall case attack rate is low, but India is a place certainly to watch. With all the crowding, it's very hard there to do social distancing, and masks are not part of the Indian culture, and so while people are wearing them there, we're worried that India is going to get overrun. In the U.S., we're at 2.6 million cases and 128,000 deaths. Again, in the U.S., where our case fatality rate is also about 5%. You know, record number of cases, just staggering number of cases in California, Texas, Florida, Georgia, Arizona, Louisiana. And so just lots and lots of cases. You remember for weeks we were saying, well, you know, the U.S. seems stuck around 20. And for a couple of weeks we were stuck around 20. We're now up to 40 million. Now, people have asked, is this due to more testing or is this due to more disease? A little bit of it is due to more testing, but most of it is to more disease. And I'll give you the numbers later from Oregon that would suggest that. Interestingly, these are mostly young people. These are mostly people with a low death rate, but in outbreaks, in many cases, young people are the harbinger of the disease. So they're the ones that go out to the bars, go out to other things and bring the disease, but then they go to work at a nursing home or they go to work at a senior care facility or they go home to their parents and then they give it to older people. So sometimes the older people may be in this second wave. So although right now it's mostly younger people and a lower death rate, we're worried that in a week or two as they bring it home and bring it to their parents and grandparents, that this is going to get worse. But even though it's mostly young people, we're starting to see overwhelming of hospitals in the South, in Texas, and in Arizona. And that's worrisome because it is, you know, the end of June, and we would really expect at this point for our disease to be about the lowest rate it would be. And so we're worried that as we get to the fall, we could see a further acceleration of cases. Oregon is continuing to do pretty well. We're the 6th lowest attack rate and the 5th lowest death rate in the country. So although the numbers in Oregon have seemed really high, it's still not nearly as bad as it is in most places. But we did add 750 cases over the weekend. The last 2 days have had lower case counts. But that's still a lot, 1,000 cases in the last 6 days. But it took us a month to get to the 1,000th case. So the long way lead up, but now the cases are coming more quickly. So the question came with, are these cases due to more case finding, or are these cases due to more disease? So in Oregon, In 1 week in May, we did 16,000 cases, 16,000 tests on 255 cases. In June, in the same week, they did 27,000 tests. So yeah, you would expect to find more. So the rate of positivity had been the same in May and June. We would have expected about 400 cases, but we really found 1,100 cases. So 400 of those cases were related to just the regular case finding that we would normally find, but 700 were because of increased transmission. And it does really seem that there is increased transmission, so we do need to be concerned about that. A couple of other things that are going on here. We had a question about how do all the parts of public health fit together? And this is a little complicated, so we'll start from the top down. So the feds, their communicable disease thing is through several agencies, the FDA, whose job it is to approve drugs and equipment, the CDC, which is the Centers for Disease Control, who's basically the infection control group around the world. There's then the NIH that has the National Institute of Allergy and Infectious Disease, and that's where Dr. Fauci works. And then FEMA, whose job it has been to distribute equipment. However, the feds give advice to the states, but they don't really kind of control what goes on, but they should have the overall coordinating function. At the state, we have the Oregon Health Authority. The Oregon Health Authority is led by a guy named Pat Allen, a really good guy. And they have a bunch of divisions, one that takes care of OHP and one that takes care of public health. Public health is led by Lily and Shirley at the state. There's some federal money that comes to the state, and then the state uses some of that money and then distributes it to the counties. So each county has a public health authority, and our public health authority is with the commissioners. And the commissioners, we don't have a board of health, so the commissioners basically function as our board of health. During this outbreak, Commissioner Freeman has been designated as the point person for this outbreak. And then I, as the public health officer and public health administrator, administer the programs. Now, what is this Douglas Public Health Network thing? Well, Douglas Public Health Network is the way we're providing some of these services. So starting back in about 2014, 2015, we had a discussion about how public health should be done in Douglas County. And the way it is the Public Health Authority resides with the county. So the commissioners and the public health administrator, the public health officer are the official public health functions of the county. But what we recognized at the time is that there were some great not-for-profits in the community that might actually be able to do better than the county running each of the services. So for example, the WIC program, the Women, Infants, and Children Feeding Program, is done through UCAN. So rather than it's coming through the county and all the stuff that goes through it, the state contracts with UCAN to provide WIC services. There's reproductive health services that Aviva provides. So rather than the county having its own reproductive health group, the state contracts with Aviva to go ahead and provide reproductive health services. There are some services related to communicable disease and immunizations that a new not-for-profit was formed back in 2015 called Douglas Public Health Network. Douglas Public Health Network is the not-for-profit that does it. And I, in addition to being the public health officer, also work in Douglas Public Health Network, working on some of their health strategy. So I have sort of split duties in that way. The county has been an incredible partner in doing this. They are totally around. I talk with the commissioners on a regular basis. They're incredibly supportive of everything we've done in public health, and I cannot count the number of times that Commissioner Freeman says, hey, whatever you need, just let us know, and he'll do it. He's constantly calling, and we're talking and strategizing about what we're going to do. So we've had really incredibly great county response. You know, they provide us the fairgrounds, and the people at the fairgrounds to help us with our drive-through. Commissioner Freeman and I go to Reedsport once a week to go ahead and collect samples over in Reedsport. So I really think when this story is fully written, we'll see that the kind of response we've had in Douglas County is very different from many other counties, but in many ways served us well. And it served us well in a couple of ways. One is, as a not-for-profit, Douglas Public Health Network can receive grants. And so we've received grants from and I'll leave some people out here, but the Ford Foundation, from Atrio, from others around who've given us grants as a not-for-profit, which we can then use to help with our COVID fight. In addition, as a not-for-profit, we're able to go ahead and get access to, for example, some sophisticated software at the not-for-profit rate. So there's lots of things that have been working that's really helped us to have what I think has been a truly remarkable response. So what is happening in Douglas County then with what's going on? So we've had a couple of cases over this last week. Most of those cases have been related to outbreaks that we currently looked at, and these were all from out of state. So out of state people came into either Douglas County people went out of state, got the disease and came back, or people from out of state had the disease and came to Douglas County. And those are pretty much getting wrapped up at this point. There are a couple of new cases today, and we're still investigating what those two new cases are. One confirmed case and one presumptive case from today. All right, so send in your questions. We'll see it. So one of the questions we had earlier are, what do you think about kids less than 12 wearing masks? Well, I was in the clinic today and saw a bunch of kids, and almost all the kids had masks on, and they were just absolutely adorable. And so they worked well. The kids seemed to have no troubles with the masks. I think the youngest kid I saw was about 2, and it was really quite cute. Kids weren't great at keeping them on, but I think it's perfectly fine. We would not recommend that anybody wears a mask while they sleep. We would recommend that not anybody use a mask if they can't adequately take it down. Second question we'd had was about this thing that was in today's press release about recovered. This has been confusing. So in the past, the state said you were recovered at the same time you discontinued from isolation. So discontinuing of isolation and recovered were considered to be the same thing. But we recognized that really wasn't the case, because there were a lot of people who had symptoms went on for a long time, and although they were out of isolation, they were really not recovered. So we were a little uncomfortable with that, but we used that definition. I think recognizing that the state and the country have decided that recovered would be a fixed amount of time from the time you first got the disease. That makes great sense in many ways. So they've used 60 days from the onset to recovered, and thus, if you use that definition, we go a long time without any recoveries. So I think what we're going to now say is we're going to talk about people who are in isolation, and those people not in isolation now are discontinued from isolation. So I think that's how we're going to report it. So read through the thing. It's nicely worded about the change in that number. So we're still giving about the same information, but as the definitions change, we give it in a different way. The next question came as about extra testing. Are most of these new cases from extra testing? No. Some of the cases are from extra testing, but there's a lot of cases that are coming because there is a lot of disease in Oregon. So Deidre says, as cases increase in Oregon, will PPE be an issue again? Yes. So I was on a long phone call today, and PPE is still an issue. Most clinics are getting only a fraction of the amount of PPE that they were getting last year. And for many clinics, they're using a lot more PPE now than they were before. So as I heard from Lane County today, PPE is in a near critical situation now. And this is, even though we've not had a lot of cases in Oregon, so PPE is certainly not behind us. So someone says, is there a possibility of a third, fourth, fifth, or et cetera waves? So there's, among us epidemiology nerds, we go through this all the time. And there's a couple of different patterns that you might see. So for example, in the 1918 flu, there was a small peak in the spring and then a huge peak in the fall, and then little peaks thereafter. I think there's lots of different patterns we're seeing. I think what we saw in Oregon was a peak and then really a fall and then a second peak. Now, whether this is the second wave or the second peak of the first wave, I think that's all semantics. But very clearly, the disease was much less active in the end of May, and then as we opened up, it got more active again. And so I think that was exactly as predicted. So people ask me when we open up, are we going to see more cases? And I said, absolutely, but we'd like to keep it to a manageable level. I think right now it's still manageable, but I will tell you in a few counties, it's getting right to the edge of manageable. When you're in Umatilla County and have more than 20 cases in a day, that's getting a little out of control. We're clearly still under control here, but it is concerning to see these cases that we've seen over the last few weeks. Some really reflect a real relaxing of social distancing standards. where people have been out, they've been out with a lot of people. When you ask them what their contacts are, they've had so many contacts they couldn't even tell you. So we do worry a little bit about these further waves of disease. So Sandy says, how are masks going to work in restaurants? Well, for me, this would probably really work if I went to a restaurant and did this. I could probably even lose a little bit of weight. Well, no, masks are not going to obviously work for patrons in restaurants. You need to take your mask off to eat and drink. We're asking workers in the restaurants as best they can to wear face coverings. And we'll talk a little bit about face coverings because I think there are several kinds of face coverings that people might consider. But I think they're going to ask the workers in the restaurant to wear masks. And if you can't maintain social distancing in restaurants, for example, if you're waiting in line or waiting in line to go to the bathroom, then to use a mask at that time. Now, in terms of face coverings, they don't have to be masks. So the three kinds of acceptable face coverings would be a mask. Second would be a scarf or balaclava like this. I prefer this because I don't have to ever wonder where it is. I don't have to dig in my pockets and figure out where it is. I know where it is every morning when I get up. And the third is to use a face shield. And there's been interesting stuff about face shields, that in some ways face shields may be preferred. They're probably almost as good at blocking your stuff. The other advantage is that people who are hard of hearing, and I think there are more of those than we know. There are a lot of people, so I'm not hard of hearing, I can understand what people say, but really what they're doing is they're reading lips. And so that when people get in masks, it's a little hard to do that. So wearing a shield makes that sense. So I just was looking at the school advice, and the school advice for teachers is that if you can do it, to use a shield so that students who are a bit hard of hearing can actually see your face and can see smiles and frowns and the other things that facial expressions say. So I don't know exactly how masks are going to work in restaurants. I would imagine maybe for cooks that they would wear face shields. I wear a face shield all the time in the shop, and it's not the least bit uncomfortable, and really after an hour or so, you kind of forget that you have it on. So Mandy says, why are recovery cases not being shown on the daily reports any longer? And the reason is because of the change in the state definition on recovered. But you'll see in the place is a number of people in isolation, and that people in isolation is the total number of cases minus the people in isolation is very close to what our previous recovered number was. So should children in childcare that are around each other every day need to wear masks? No. And so the story is kids less than 12 are not really required to wear masks. Again, remember three things about kids less than 12. They tend to get the disease less often, they tend to be less sick, and they tend to spread it less. So if kids in childcare want to wear masks, that's okay, but I don't think there'll be any requirement that they do so. So do cloth masks protect the wearer from COVID? Wendy asks. Well, a week ago, I would have said there's not very good data, but Dr. Bierks presented some data the other day that thought that cloth face masks may help the wearer. I don't know. When I looked at the data, I thought it was a little soft, but they might protect the wearer. The concern was early on that by people wearing masks and touching their faces all the time, they may increase their risk, and I haven't seen that data yet. So I would say, if the question is, do cloth masks protect the wearer from COVID, I would say maybe. There's another great video coming later this week that will explain a little bit more about how social distancing and masks work. So we're at 40 confirmed cases. How many have been recovered? Well, according to which definition? According to the previous definition, which was discontinuation from isolation, it was 32. However, you use the new definition, depending upon when you applied it, the number could be anywhere from a few to 32. And that's why we have chosen to report the number in isolation, which today I believe was 8. So if somebody gets diagnosed at a workplace, what's the protocol? So in workplace outbreaks, when there are 2 or more cases, we hear about it and we track down contacts in quarantine and do all of those things. When there are more than 5 cases, These get reported through the OHA, and the OHA does a special release about a workplace outbreak. So far, we've not had any workplaces with more than 5 cases. So how are we counting people who've had a positive antibody test? So a positive antibody test, so positive antibody is a blood test that would show that you might have had the disease before. But remember, these antibody tests are a little problematic because some of them have had a low sensitivity and a low specificity. That is, there are lots of false positives and false negatives. So the state has considered that people have had symptoms and a positive antibody test would be what we call a suspect case. And so suspect case is something that we follow, but obviously the antibodies, we're not doing anything other than counting in there as a suspect case. I believe we've had 5 positive antibody tests. Only one of those is even the least bit surprising. Yeah, so if a worker that tests positive in a given county but doesn't live there, where are they counted? So typically in people with stable housing, their county of residence is considered to be the county that it goes to. So we've had a bunch of cases actually from California. People come up to Oregon, test positive. So it's a positive test in Douglas County, but it counts back to the county where they live. If people have unstable housing, then it's in the county where they're diagnosed. Yeah, so Becca says, how do masks affect those working out in a gym? Still required? So what we would want is for people to wear masks until they can socially distance. We hope at your gym you're adequately socially distanced and standing still. So once you get into a public space and you're socially distanced and you're stable, you're stationary, you can take down your mask. And that's what we're hoping. So I go to the gym every day. I wear my mask, my balaclava. As I get into the gym, I find my exercise cycle in the room all by itself. I look around, nobody else around. I take my mask down, exercise, and when I'm done, I put it up again. And that's what I'd recommend you do. Yeah. So Misty says, now that it's mandatory to wear a mask, how can we as store clerks enforce rules with customers? So stores are allowed to ask customers to wear masks. There's no really great enforcement on masks. I mean, we really do not have mask police, so I'm not sure we can do it. I think what we can try and do is set a good example and ask people to wear a mask. So if people have other ideas on how we can do this, I want to do this. As you know, a few weeks ago we had a stabbing related to a fight about masks. I really don't want to go there, but I think wearing a mask can really protect others, may actually protect yourself. So I'm hoping we're going to do it. I think we're seeing a national shift. At this evening, there was a real national shift among people about the use of masks, and I hope the politicization that's gone along with masks will go away. Yeah, so Dale says, is the virus that we're dealing with now different from the one that originally appeared in Wuhan? And this is very interesting, because remember we've talked about mutations, some that make it weaker or stronger. So there's a mutation which is called D614G. So the story is that we can look at genomes very quickly now. I mean, it used to take weeks or years to do a genome, and now we can do it overnight. And so what they do is they've looked at the genomes of the different viruses, and in the 614th position of the surface protein, there's a change from D to G, which is the change of the nucleotide, which changes the protein a little bit. So for those who don't exactly remember their biology, DNA encodes the protein structure. RNA is like the scratch pad, and then the RNA gets together, and then based on the 3 nucleotides, you wind up then with a different amino acid. So switching this switches the amino acid in the middle part of the protein. And it turns out that this switch actually makes the spike protein stronger. So in the original kinds of the virus, the spike protein was weak and would frequently break off apparently and not allow the virus to get in. This one apparently makes it stronger and actually may make this more infectious. Probably not more deadly, but maybe more infectious. So these are the things we're going to see. Now, the good news on that is that it's not more deadly, but the bad news is if it changes the spike protein, is it going to change the body's ability to respond to a vaccine appropriately? And that's the answer we don't know. Yeah, so Deidre says if spread is more prevalent in enclosed spaces, how does a shield protect better than a mask? Is it airborne or droplet? We think, again, most of this is going to be, at least start off as droplets, may occasionally get aerosolized later on, but we think it's going to be droplets. And again, a shield that goes below your chin, again, if you cough, sneeze, or talk and make droplets, they're mostly going to get stopped by the shield, and that's the way it's going to work. And again, this doesn't need to be perfect, right? You don't need to protect against every virus, but by decreasing the amount of virus, you tremendously decrease spread. So somebody gave me a great example. They said, you know, it only takes one sperm to make a baby in the egg, but if you had a sperm count of 1, you would never make anybody pregnant. I mean, it really is, you probably need an infectious dose of 500 or 5,000 viruses in your body before you get it. So this idea that this one lone virus can make it in is not realistic. You do need a minimum infectious dose. And again, if you can decrease the infectious dose by using the face shield, you're doing a good job. So how much additional protection will eye protection give you? There was one study from the Oxford group, and it suggested actually the eye protection was a few percent additional protection. And that's the other reason that the face shields help, is because the face shields give you very good eye protection. So again, face masks, face shields, whatever you choose, but just please use something. So Desi says, how accurate is the antibody test now? Well, so when the antibody test came out, there were a huge number, 90 or 100 of these tests that came out. Some of these were these little lateral flow assays, some were bench tests, and the variability, they were tremendously variable. The FDA then, after a month or so, said, hey, you have to give us data that shows how good your test is, or take it off the market. And a bunch of these tests were removed from the market because they either didn't give data or the data that they gave was terrible. If you get one of the lab antibody tests from Mayo, from OHSU, from Providence, from LabCorp, from Quest, I think they're accurate enough now to totally use. Now the question is, do they really help you? And I'm not sure how an antibody test really helps you. The other thing that came out just today was a study that looked at the persistence of antibody. So the persistence of antibody means if I have an antibody level now, what will happen over time? There's some diseases where you get an antibody and the antibody stays up for a very long time. So for example, measles, I had measles back in the last millennium. And if you drew my measles titer now, it'd still be pretty high titer. We're seeing in this one, it falls off pretty quickly. And even within 90 days, people are seeing a really big drop off. There was a study done in Oregon at Providence, and they looked at the antibody levels, and within a few weeks, everybody's antibody levels were down, and some were down to a point where they're no longer detectable. So the antibodies may go away. So if you had a negative antibody test now, it could be because you didn't have the disease. It could be you had the disease, but the antibodies are now gone. Or it could be a false negative test. So again, I'm not, except if you're looking to donate convalescent plasma, not exactly sure how an antibody test helps that much. So Misty says, once a person has recovered, should they still wear a mask to prevent transmitting disease? So one of the things that we've looked at again and again and again is how long after you have a positive test can you make virus that could actually infect somebody else. And I think the consensus is no more than 9 days. To be extra sure, we go 10 days from the positive test. Now, you may still have a positive test 2 weeks, 3 weeks, 4 weeks later, but we think that's like, as I say, bugs on the windshield. They were alive at one point. They clearly are bugs, but they aren't live anymore. And that's what we think of these later tests. So we think 10 days after diagnosis or 3 days after your last symptom, whichever is longer, will prevent you from transmitting the disease, and then you no longer need to wear a mask. So Rob says, KEZI said 8 people in the county are in isolation. That is correct. Are they isolated in their homes or somewhere else? And how does that work? So if you're isolated, you can be isolated in a number of different places. I think many people are isolated in their homes. And so if you're going to be isolated, for example, at my house, you could either be isolated alone in my house, which would mean I'd be in my own separate room, meals delivered to the door, or we could isolate as a family. If you isolate alone, you need to isolate for 10 days. If you isolate as a family, you need to isolate for 24 days, because obviously on the 10th day, when I could still maybe be contagious, I could maybe expose somebody. It would take 14 days for them to get it. So if you're in a family group, you can isolate at home, either individually or isolate as a family. There are some people who don't have homes, and they can isolate elsewhere, like a motel room or somewhere else, or with friends or relatives. So people are in all different places. We know where they're all at, and we call them every day to see how they're doing. So you can isolate in those places. We do not isolate people in hospitals. It's really, if people are low symptomatic, there's no need for them to be in hospitals, and we don't have any other special isolation facilities. Right, Donna says, if you recovered from COVID and gave convalescent plasma, does that reduce the number of antibodies left in your body? And the answer is yes, very transiently, like for an hour or so, it decreased the amount of antibodies you have. But remember, when you give plasma, you're only giving a tiny fraction of the plasma that you have, and your body is incredibly good at making antibodies. So within a very short time, they come back. So Brenda says, are we expecting a complete shutdown? Oh my goodness, I hope not. So the story is, what do you do if this disease starts now getting worse and you start getting into a bad situation like they are in Arizona and in Houston? And I think what you can do is you can move back. And certainly Texas has moved back a lot, right? They stopped elective surgeries. They repurposed their children's hospital to take care of adults. They closed bars. They closed restaurants. And once you do that, more people are going to be out of work. So yeah, you can move backwards. You can move backwards to a total shutdown. I certainly hope not. I think economically, a total shutdown at this point really would be quite devastating. And I think just people's confidence would be so hurt by that. So we're really trying not to go there. So what can we do? Wear your mask. What else can you do? Avoid social distancing. What else can you do? Really be careful about travel outside the area. Again, very little disease here in Douglas County, but a lot of disease at the coast in Lincoln County, a lot of disease up in Portland, a lot of disease up in Umatilla, a lot of disease in other states. So please stay in Douglas County. We've got a beautiful county. We're going to have a great fireworks show. Really don't need to leave, and really think about that. Almost all the cases we've seen have been with out-of-state travel and mostly with parties. Really, I think we need to hold off on parties for another couple of weeks. People do need to work, so shutting down the economy is really hard. Yeah, parties are great, but I think we can hold off on those for a few weeks. So Brenda says, if somebody's isolated in a hotel, how are they sanitizing afterwards? So so two things you could be doing. You could be quarantining in a hotel. And if you quarantine at the end of the 14 days and you're not sick, then that's the only person in the motel that I can guarantee doesn't have COVID, right? Because I could be having COVID, stay in a motel and leave the next morning, and then I would have COVID in the motel. So the only person I can guarantee does not have COVID and is not infectious is the people who leave the motel from isolation and quarantine. No special cleaning is needed 24 hours after you're infectious. Since we think these people are no longer infectious, no special cleaning is required. So how long do you need to wait after being exposed to a known case to get tested? Well, so let's say you get exposed on July the 1st, tomorrow. So if you get exposed on July 1st and get tested on July 2nd, 3rd, or 4th, it is unlikely that if you were exposed or aren't going to get it, that the test would be positive on the 2nd, 3rd, or the 4th. Usually the symptoms show up on the 5th or 6th day after exposure, which would be on the July 6th or 7th. And the most likely day to test positive is the 7th or 8th day. So if you got exposed on July the 1st, I would recommend, if you're going to only get one test, that you get it on the 8th or the 9th. Now, there are some people who have been exposed and have gotten tested multiple times. That's certainly okay. But if you were going to get tested one time, it'd be 7 or 8 days after exposure, since that's the most likely time. Now, remember, a negative test doesn't give you the hey, you'll never get this. But if you're going to find one time to be most likely positive, it'd be between 7th and 8th, maybe up to the 12th day afterwards. Okay, so a few other things that have happened here. Okay, so somebody says, is it safe to get a massage? Okay, so remember the three things that characterize the kind of exposure is the amount of transfer of fluids, so kissing somebody, having a close conversation, are areas where you're going to have that presumably in a massage. You don't have to have that presumably in a massage. Both the person getting the massage and the person giving the massage can be masked, but still, just arms being as long as they are, you'll be in close contact. The second is length of time. And so length of time is clearly a difference. And you'll see in this YouTube video we're doing why time is so important. So, 15 or 20 minute massage, much less risk than a 1 or 2 hour massage. And then the third one is the setting. So if you do it in a crowded little place, probably more risk than if you did it outdoors. And I don't think there's any reason you can do a massage outdoors. So if I were going to get a massage, I'm not big on those, but if I were to get a massage, I would try to do it outdoors. I would try to have a relatively short massage, and I would be sure that both I and the person giving the massage were wearing masks. So keep sending in your questions here. So Deidre says, are the tests still free? So a little complicated. The tests are clearly not free, right? The test costs, so the sort of the list price of those is $200. We think that statewide the tests really do cost about $100 to do. I mean, there's a lot of steps in here, and there's primers and RNA and expensive equipment and whatever, so they cost about $100 to do. The deal we have with Quest that we do through our drive-ins, we have a deal with Quest that people will not get a bill for those, and we don't think anybody's gotten a bill yet. And the reason for that is they're banking on the CARES Act, which said that labs that provide these tests will get compensated, and they do not need to charge the patient anything for copay or deductible. And so far, they've been good to their word on that. So those tests, at least to this point, appear to be no charge to the person getting them. Obviously not free. Somebody's paying for this. Probably your insurance, maybe Medicare, maybe Medicaid, maybe the CARES Act for the uninsured people. The other tests, we have no guarantee that that's the case. So antibody tests, the CARES Act is so vague that I don't know if it's going to cover antibody tests. The other tests, the antigen tests, again, I do not know on the CARES Act whether these are going to be covered or not, and I never want to tell people that you're not going to get a bill and then you wind up with a bill. The other place you can get the tests is through the State Public Health Lab, and the State Public Health Lab does tests of high public health importance, like confirmatory tests and other kind of things. The state does those, and the state picks up the cost for those tests. So if you get a test through the State Public Health Lab, or if you get a test through one of our drive-ins, you will not get a bill for those. The other ones, not so sure. But the tests are expensive. So, I mean, these people were paying for these tests. They might think twice about getting them. And the thought early on was we didn't want people not to get a test because of the fear of getting a bill, right? Because imagine if you were sick and work in a nursing home and you want to get one of the tests, and you say, but I don't really have a lot of money and I don't have insurance, so maybe I won't get one. We wanted to take away that disincentive. So again, come through our drive-through. There was a little hiccup today on the drive-through, so that if you have a doctor, we would prefer you get the test order from your doctor. That way your doctor is involved in your care, and then we certainly get the results. If you don't have a doctor, don't want to go through your doctor, you can call to Aviva at 541-459-3788. Now, a couple of people showed up today thinking they were going to get the test at Aviva. No, no, no. The story is that's where they'll get the order from. We'll do the test at our drive-through. All right. A few more things here. One is about this about number of tests. So there's been a sort of an idea that if we just did more tests, we would do better, and that's not exactly true. And so the story is doing more tests is useful if you're going to do something useful with the results. So there was a good article today that said that if you looked at all the places, there's some places in the country that have such widespread disease now that further testing is really not what's needed. So that if you look at, for example, Texas, further testing at this point isn't going to really tell you anything. You know the disease is widespread. What you need to do in Texas is you need to just batten down the hatches, stop people from circulating, and let the disease come down. But if you're in an area that has very little disease or just a little, so either very little or a little disease, like we are in Douglas County, that's the time you want to do testing, because if we get a positive test, we know exactly what to do. We isolate and quarantine, we track down all the cases, and we can do that. There's no way with 6,000 cases today in Texas that they could track down each of those cases. But when we have 1 or 2 cases, we definitely can, and we totally track down each case, so that the testing should be dedicated to the places that are at low levels of disease. And then you should push the testing in those areas until you get the positivity rate less than 2%. And so that's what you need to do, and so I would aim for doing that in areas that have gotten disease pretty much under control, and then driving their numbers down to 0. And that's exactly what people did. So I looked at the percent positivity rates in different areas. So the U.S. percent positivity rate is still around 8 or 9%, which means there are plenty of places in the country where you do need more testing to drive that rate down to 2%. In India, 15% of the cases are positive. They're totally out of control. In Brazil, about half the tests are positive. They're totally out of control. And what they need to do is other measures to bring the disease down. But when you look, for example, at Australia or New Zealand, they're way less than 1%. And so they've done the job of bringing the disease down. Again, in Douglas County, we're still much less than 1%. So we're doing a good job. Overall in Oregon, we're at 4%, which means we still need to do more testing in those areas in Oregon where you're still seeing a lot of disease. And there's still a lot of disease up in the Tri-County area, and they should be doing more. So Yvette says, should an essential worker wear a mask inside the house around the rest of the household? And you could, wearing a mask 24 hours a day is very difficult. Hold a second. It's very difficult. And household exposures are so hard to avoid, so that there are no recommendations for wearing masks around the household. Now, if you've got a big big household, that's a risk. So Dale says, do you have to worry about contamination on the outside of your balaclava? I don't think so. I think the outside's the outside and the inside's the inside. So there's no perfect way to do this unless you're to wear a mask early in the morning and leave the mask on the whole day. That's really uncomfortable. So what do you think of the suggestion that CPAP makes COVID worse? We don't really know. There's some interesting things about the ventilation of people who have COVID. They have, for example, oxygen levels that are so much lower than you would predict based on the clinical pattern. In fact, early on in this disease, there were a number of people who had oxygen levels. They said, oh, there must be something wrong with the machine. You couldn't be talking and texting on your phone with an oxygen level in the 50s, and yet they were. So there's something funny about the low oxygen levels you get. The other thing that they found is that ventilation doesn't help that much. So when people get on ventilators, it's really, really hard to get them off. which is really unlike most other diseases. Most other disease, you have bad lung disease, you put them on a ventilator a few days, let the lungs take care of this, and then you're back to good. This is not what they're seeing with COVID, where many of the people who go on ventilation then wind up dying. And the other thing that they found, which is really bizarre, is that simply turning people over on their bellies will make them so much better than otherwise. And that's really peculiar because we don't think there are any other adult diseases that follow that pattern. Now, interestingly, in babies, babies will frequently do better on their bellies than on their backs, but that's because they have very weak respiratory muscles, but we're not really sure about that. In terms of CPAP, we don't know about this, whether it makes it better or makes it worse. Now, in some cases, you think it should make it better because it does make other respiratory illnesses better, but we don't know yet about COVID. Where every day we're learning new stuff, and I seem like I probably drive my wife crazy, but every day I'm reading all these different articles and doing things because there's so much new every single day. So the question is, do I see any hope for a vaccine? Yes. So I was on a conference again today, and the state epidemiologists were going through the several different vaccines that are out there. So I definitely see some hope for a vaccine. Do I see some roadblocks? Oh, absolutely. So again, we've never had an effective vaccine for respiratory coronavirus. So this is coming up with the virus for a new disease. The leading diseases are mRNA, messenger RNA vaccines. That is, you make an RNA, which is the little scratch pad that says make the spike protein. You inject that. Some cells in your body take up this mRNA and say, I should make some spike protein. They make the spike protein. They put the spike protein into your bloodstream. Then your body says, this is a different protein, makes antibodies against it, and it works. So it's a complicated pattern. We've never really had a working mRNA vaccine. We've never had a vaccine for a coronavirus. So this is all a little worrisome. And with any vaccine, there's lots of problems along the way. You could have, for example, people have allergic reactions or have other reactions to a vaccine. Then if you get the vaccine there, the idea of producing 300 million or 8 billion doses of vaccine is daunting. And there's so many little steps along the way. So one of the things I've been nerding out about this week is something called borosilicate glass. So borosilicate glass is this special type of glass which is very resistant to temperature changes, so you can sterilize in the glass, and is special glass. Well, you need to make it with special sand, and there's a shortage of this special sand to make this special glass, which is the glass that these vaccines go in. So there's a lot of steps along the way that would be difficult. Then if we finally got this vaccine, giving everybody 1 or 2 or 3 doses, what you required, would be very difficult. And then I also worry about people accepting the vaccine. We have a lot of people who don't want to get vaccine for whatever reason. And the question, will people worry about this vaccine? And I think they could worry about it because it was produced quickly and people would worry about the safety of it. They might say, well, another couple of million people go ahead of me and I'll see what kind of reactions they have. And then if there are some unusual reactions, so for example, in the past, when we had flu vaccines, sometimes they were associated with a syndrome called Guillain-Barré syndrome. And so people may worry about side effects like this. And we also worry that with a vaccine, that things could happen that would be definitely true, they definitely happened, but not related to the vaccine. So let's say you got the vaccine on September 1st and September 8th you won the lottery. I don't think you'd say, wait, geez, I won the lottery because I got the vaccine. And both would be true. True, you got the vaccine, and true, you won the lottery. But people would say, come on, there's no relation. But what if you got the vaccine on September the 1st and then on September 8th had a stroke? You might say, well, wait a minute, I was fine and now I have a stroke. And you'd worry that the stroke might be related to the vaccine. And, enough people wrote on Facebook, like, wait a minute, I had that too. I had the vaccine on the 1st and got a stroke on the 8th. People might think that there was a relation. And there would be a way to prove that, but it would take weeks or months or years to prove or disprove that there was a connection. And the way you would do that is you'd say, well, on September the 1st, 1% of the people a week later had a stroke, and of the people who didn't get the vaccine, 1% later got a stroke. And then you say, well, it's true that you had the stroke and had the vaccine, but there's no relation. But those kind of studies take a long time. So, for example, with MMR and autism, I think everybody at this point agrees that there's no connection between MMR and autism, but it took 10 years to go ahead and show that lack of correlation. And so I worry about that. So what I'm saying with the vaccine, there's a lot of hope out there. There's several incredibly good vaccine candidates along the way. There's a lot of work going on. There's a tremendous amount of money there, but there are some roadblocks along the way. Never made this kind of vaccine, never made a vaccine against a coronavirus. Even if you make it, we're not sure it's going to work. And then if you make it work, you have to make a lot of these things. There's a lot of details in doing this. Then you have to give it to a lot of people. Then people may not want it. Then you may see side effects. So there's a lot of roadblocks along the way. I'm hopeful, though. But I think the end of this could be a vaccine, but it could be a very effective treatment. So let's say we came up with new remdesivir that was 90% effective, and it turned this from being a terrible disease to something you took a pill for. That could do it. Let's say you found a really effective biologic agent. That could end it too. Yeah, so Aaron says, what's the sensitivity and specificity of tests with saliva or regular Q-tip? Oh, I just asked this question this morning, didn't I? Or it was yesterday, I can't remember. So, we started off by doing these nasopharyngeal swabs, which are these 5-inch long swabs that you stick, it seems like, right into your brain. They're really distinctly uncomfortable tests. I've had it done a few times. And really distinctly uncomfortable and hard to collect. You need people who really know what they're doing. They require very special swabs to do. So all along the way, we said, boy, wouldn't it be better if we could get another test using either saliva or just in the front part of the nose. So right now, there are tests that use all of those. And what we're waiting to see is the head-to-head test. So what you'd love to see is somebody who is foolish enough to have all 3 tests at once, and then you compared the sensitivity of the 3. The Chinese did that, and they thought the nasopharyngeal was superior, but that was months ago. So actually, University of Oregon is going to do a test looking at the relative sensitivity of the 3 different ways. Boy, if we could get a spit test, that would be great. The other thing is if you could get a spit pooled test, that would even be better. So a pooled test is where there's a disease which is low incidence, and you get everybody to go ahead and give their specimens at once. You test the one pool, and then if that's negative, then you consider everybody to be negative. If that's positive, then you test the individuals. So, my sense is, okay, let's say you had the football team. At the beginning of practice, everybody spits in the tub. You test that while they're practicing. By the end of the practice, if it's negative, then everybody's good to go, and you repeat that in the morning. If it's positive, then you go ahead and test the individual players. That would actually be a strategy for getting us back to pro sports. I'm not sure we're quite ready to do that for high school sports, but I think it would be a great idea. So Brandy says, do you feel like a surgical mask is different than a cloth mask in protecting us? So they have done these studies, and they look at the relative efficiency of masks. And the numbers are something like an N95 mask protects against 95%, surgical mask between 60 and 90, and a well-made cotton and a well-made cloth mask anywhere between 40 and 70. So there's a lot of overlap between them. So, if people want to wear N95 masks, that's fine. N95 masks are really tight and are really uncomfortable. There are not many people going to want to wear an N95 mask all the time. I think a surgical mask, perfectly fine, and I think a cloth mask, perfectly fine. I think what you'll see is that they both decrease transmission from you to others considerably. And again, if it protects at 60% or 70%, both are great. So 60% is so much better than 0% that I would encourage everybody to wear a mask that they can feel comfortable with. And so that if you're comfortable with a surgical mask, go for it. If you're comfortable with an N95 mask, go for it. If you're comfortable with a face shield, go for it. But please use something to protect others. Okay, well, I'm told that I'm turning into a pumpkin soon. So we'll go. Again, this is Dr. Bob Dannenhoffer. We'll be back on Friday. I know it's a holiday, but we're going to do a special holiday 4th of July event. But before the 4th of July, if people are planning, I would plan to do a few things. Please go outside and get some fresh air. Please go out and enjoy the thing, but avoid crowds. Avoid getting really close to people. Wear a mask if you're in a public space where you can't maintain social distancing, and celebrate the fact that we live in the greatest country in the world. Again, Dr. Bob Dannenhoffer, thank you.